Hello, everyone. This is Shadi Ray from CVI 2025 in Austin. I'm really privileged to be with Dr. Abdallah Sabbagh to talk about TRIM, transcatheter removal of intracardiac masses. This is a new terminology. So, Abdallah, thanks for being with us.
Thank you, Shadi, for the invitation and for being here. And really excited to talk about this topic. No better place to talk about an innovation.
Except the innovation center,
Exactly.
Right? So tell us about this new terminology and what are we doing now in that space?
Yes, exactly. So in the past years, obviously there was the evolution of devices to remove clots in pulmonary embolism. And we then soon recognized that we can use these in different parts of the heart and pretty much vacuum the heart from clots, masses, and all sorts of mobile echodensities and foreign object removal too. So we've extrapolated the use of these devices, and then now there's also other mechanical devices like the Ono basket and whatnot, coupled with accessory devices. So now this is an evolving field where we're trying to emulate what the surgeons do, this kind of similar techniques, but in a transcatheter way.
Nice. And so the indication for this is what? Patients are the surgical turn down or usually come to you as a first person to take care of it?
Yeah, so typically they're surgical turndowns, and they're typically older comorbidities. This is the patient population that we're doing now. And obviously, as this evolves, our experience evolves, devices evolve. I do think that there's an opportunity to do them minimally invasive without open heart surgery. Just imagine, it's always difficult to send, although it's indicated, but it's difficult to send a patient with a tiny PFE to open heart surgery. But so that's where the need.
So a lot of people in public knows that this is indicated for vegetation or a big clot in the LA RA or transit. But you're telling me also there is a PFE as well, like it's some fibroelastoma, right?
Mm-hmm.
So walk us through how this is kind of doable without damaging the valve.
Yeah. So the different types of different types of masses, obviously not just PFE. So we look at the consistency of the mass, the stock. And then the attachment, and there's certain for example, if it's too small, it's not doable. We can't visualize the snares, we can't visualize the equipment interaction with the mass. But if it's a big mass with a tall stalk that we can visualize the snare, because often we have to cut the snare while we're aspirating.
Yeah.
So we typically sometimes if we're able to visualize the snare and make sure that it's not interacting with the valve, that's how we avoid valve injury. Early in our experience, especially with PFEs, there was one case of a valve injury, and that was the mechanisms. We couldn't visualize exactly where the snare was.
Speaking of imaging, what imaging tool do you use for imaging to guide you?
Anything that gets you the best images. Honestly, this is an example.
Yeah.
It's a tricuspid, under the tricuspid, under the septal leaflet, where we know from tricuspid interventions it's the most difficult location. So we use TEE, we use 3D ICE, everything possible to see it in different views to make sure that the snare is, again, wrapped around the stalk and not interacting with other structures.
Yeah. So this is the case that 3D printing, you use the 3D printing
Yes.
for planning the procedure?
Yes.
So walk us through it then. How do you usually do it?
So I mean, we wanted to see, because this is the location of the mass. It's under the septal leaflet of the tricuspid valve. So the best straight shot is going to be from the IVC up, curled with an angiovac. So it gives us the best orientation to be right opposite to the mass. And so this is exactly what we do. So it helped us plan it and remove it just because of that.
And this is a CT generated image?
Yeah.
Model?
Yeah, a CT, and then we printed it.
So now with this new technology or this new field is becoming like a new structural space. Usually you have the same setup, like you have a team meet together, say what's the best approach?
Yes, so we have that. We have a interventional cardiologist, cardiac surgeon, imager, and a cardio-oncologist for the natural history, etc. If it's endocarditis, we have an endocarditis team with ID. So it's definitely a multidisciplinary approach to these, for sure. Yeah.
Do you use perfusions for all your cases, or depends on the device?
So it depends on the device, depends on the mass itself. For PFEs, if you do something that's non-continuous flow aspiration, it can actually fall apart. So that's where the consistency, knowing the consistency. Sometimes we go to the pathologist, or when I started doing them, I went to the OR, to the surgeons, just to feel these masses. So PFEs can fall apart. So it's best to use continuous flow aspiration while manipulating or trying to remove, etc. So if it shreds, gets pulled into the
Right. Makes sense. Okay. Well, thank you, Abdullah. Thanks for a great overview.
you.
TRIM is a new terminology.
TRIM.
Transcatheter removal
Yeah.
intracardiac masses.
And that's what we do to the masses. We turn them. Yeah?
Thank you.
Thank you for having me.
Watch these videos on others' YouTube channel. This is Shahid Grace coming to you from CVI 2025.